Welcome to Innovating Clinical Trials, the podcast designed for clinical research professionals eager to deepen their understanding of clinical trials through concise, insightful segments. Join your hosts, Liam Eves and Ted Trafford, as they uncover the core issues in clinical research, reflect on the industry, and challenge conventional wisdom.
Welcome back to part 3 of our conversation with Jill Fikowski, founder and CEO of Changemark Research Plus Evaluation. If you haven't listened to the previous episodes yet, go back and listen to part 1 and part 2. You won't be disappointed. Now, on with part 3. As you and Liam were speaking, one of the things that came to me was the topic of retention in clinical trials, because actually many of the clinical trials that we do, we test on medications that maybe take a long time to work or see results. And so what are some strategies that we can employ that is actually going to help people want to stay in a trial when they're maybe not seeing something for weeks or months? And so I'd love to get your thoughts on, it's one thing at the end of the trial to present this information with the community groups, but what kind of information and how can we continue to engage people throughout their participation in the trial, not just at the end?
Yeah. Retention is a huge consideration on research teams with people who use drugs. Across all, really, like depending on the study. It's not just people who use drugs, but that's my experience. So, people stay in studies for lots of different reasons, right? One could be that they're getting contact with their physician on a regular basis, when really they would have to wait for an appointment with their physician for months. But now the study allows them to kind of come in and get that clinical care regularly. Some people want to contribute and feel like, wow, I'm contributing to something. Like, this is great. I want to keep coming because this is something that's really important to me, right? Some people come and it's the relationship with the research staff because they're lonely and they want that human connection and they want to sit with someone who cares about them for an hour, or maybe it is the compensation. Maybe that's what their needs are that day, right? It's understanding what the participant needs, not just the needs of the protocol. This is where we have to get to, right? When we're developing these, is what do the participants need? And the only way to know is to ask them. So, and again, it kind of circles back, right? And, retention, it's very interesting. I have a very interesting study, actually, that I had on my list to talk about, because this is a classic case of a multi-million-dollar study that was given funding. It didn't fail, but the enrollment and retention went off the rails a little bit, leading to about a 2-year extension in timeline and funding. There were 2 already marketed medications for opioid use disorder. So folks could get randomized to one of these 2 marketed medications for opioid disorder. Okay. And they got funding for this. So each province in Canada has different regulations around access to these 2 marketed medications. In some provinces, folks can get access to either one very quickly. In some provinces, there's all these restrictions and barriers to people getting access. So in some provinces, being in the study would be a huge draw because I can get access to this medication that I otherwise couldn't get access to. But in some provinces, it's like, whatever, I'll just drop out because I can get this wherever I want. And I don't even like this one anyway. They put me in this arm, but I don't like this medication anyway. I've tried it before. It doesn't work for me, right? So what we found was it varied from province to province based on legislation and regulations around each of those drugs, right? Which wasn't thought about ahead of time. Mm-hmm. But also, opioid users are pretty clear on which drugs they like and don't like. So if they get randomized to one of these opioid agonist treatments, they might not like it and just drop out and go get the medication from their clinician because it's pretty easy access, right? So interestingly, we would have probably known attitudes and prescription preferences if, folks would have engaged ahead of time to say, well, here's what we want to do. What do you think? Oh, no, I could get that anywhere. I wouldn't bother. Right? Or here's what we're paying for honoraria. I wouldn't show up for $15. Like, these are things that you only learn and find out. So yeah, retention is tricky. relationship, complex and complicated study procedures, overly complicated, right? Location. If you're located at a hospital and your site is at a hospital and you're recruiting from a location that's maybe 2-3 kilometers down the road, don't assume everyone can make it. What about folks who, have trouble with access or who have trouble with mobility, right? Are you giving out bus tickets for them to get here? Are you expecting them to make it adventurously across the city on their own? Right. And so when people go, oh, it takes me 2 hours to get there, I'm not going to go. Right. Mm-hmm. It's, they won't go, or even meeting people where they're at. Right. Well, you have to come here to complete this questionnaire. Da, da, da. I've sat in alleyways with my outreach partner with a questionnaire package, asking people questions. Right. Because that's where they were. You're meeting them and within reason, be safe. Right. but right. But you're going to them, meeting them in a space that they're comfortable with. And, and so, yeah, it's a respect thing, but yeah, retention is always tricky, but it's understanding the participant and what their needs are. And, maybe when I've seen HIV trials actually that show up and, for blood draws, and people are keeping them there all day and taking, 10 to 15 blood samples and, giving them $50 honoraria for the day and saying, okay, and then driving them back to their community. Thank you very much. It's like, okay, well, you got your 10 to 15 vials of blood and, they got $50 and, and so there's lots of reasons. So people go, oh, I'm not spending the whole day for that. And I don't want to get that many blood draws. And so lots of reasons, people don't keep coming to visits, but yeah, I hear you for sure. Yeah. It's a tough one.
Yeah. I love earlier in our conversation, you talked about, I think essentially I'm paraphrasing here, but the approach to the study being, how can we help as many people as possible instead of having the attitude, how can we recruit as many as possible? Because I think often the lens is, okay, we need to recruit quickly. And maybe if we just flipped the script and said, how many, we believe in this project. Mm-hmm. We believe this is an important study, and how can we reach as many people as possible about it?
Yeah.
And what does that look like? And does that change our approach then if we just simply took a different way of looking at it?
Mm-hmm. Yeah. Well, and research coordinators are under incredible pressure, right?
Yeah.
PIs and sponsors are, yes, but the research coordinator, I'll speak from experience, is the one who takes the brunt of, we're not meeting our numbers. We have to increase enrollment. We have reporting deadlines. We have this and this and this. This leads to a whole mess of problems. This leads to coercive practices. This leads to, people trying to rush people in, rush through assessments, get people out the door, complete as many as possible in one day, rather than taking the time that you need, right? And but these could all be enrollment retention issues could all be solved from inception of the study and when it starts. Anybody who's kind of coming in, it's kind of like an organization running out of money and then bringing in a fundraiser. It's a little late, and so we're 2 years into the trial and you're having trouble with enrollment retention. We probably should have thought about that 2 years ago, but
Yeah, it's so funny. I often see, and I've just had a conversation not long ago about how as an industry, we're very interested in getting that first patient in. And we never really think about the last patient process or the last patient of when they're going to be in. But I think that, to your point around there's perhaps friction, right, around that you need to do that upfront work, because I think it's a great question as Ted brought up there around the reframe to say, how do we help people as much as we possibly, can within the research and framing that question to be in a position where of adding value. And I think that people are always, and I think it's done subconsciously, which is, what is my value equation that I'm running in my head here? Mm-hmm. And does that value outweigh the burden that it's stripping? Mm-hmm. And that people are making those, whether you like it or not. And it's like, I think that we all too often as an industry, like, we will focus on a few of those areas and we'll try and reduce things like the logistical burden for an individual, but we don't necessarily think about the full equation, which I think is, to your point, is part of the problem.
I love what you said about, what happens, and we often don't think about the last participant, last visit, right? And it's kind of like, okay, we're done. We've got our numbers, this and that. But I will tell you, people have shared their experience with me about being involved in some of these psychedelic assisted psychotherapy programs. This is not something that, stops when it's their last visit. This is something that fundamentally changes their life. And the thing is, in the psychedelic industry, what I'm noticing right now is, yes, it'll change your life. It's miraculous. It's this, that. I've heard the opposite too. I've heard it completely stabilizes me. It's caused problems. It's me and my partner have grown further apart because of it. My trauma all got brought up, and now I don't know what to do with it. Right? These are all things that happen after the last therapy session that no one follows up on or talks about. There's a wonderful organization called Psychedelic Lived Experience. And I've watched several of their kind of podcasts and clips of people who have gone through this experience. And, of course, pharmaceutical companies and sponsors want to talk about the good things, because this is what generates investor dollars and this is what generates, profit and stuff. But, we also have to think about, here's some of the risks in people's experiences as well. And it's not all so good. It can be good, but it's not always good. And it's okay for those two things to live in the same place. Sometimes it's good, sometimes it's not. But you're right. We collect our AEs, they have their last visit, we input the last data, database log, and then the participants, no one follows up with them really. Maybe because they're worried, it's not our responsibility anymore because the trial is done. We don't want the liability. What happens if they're not doing well? Do we have a responsibility to take care of them? And, but you're absolutely right about what happens afterwards. Mm-hmm.
Yeah. Well, last participant, last visit seems like a good place to wrap up the podcast.
Yeah.
Love having you on today, Jill. Really appreciate your time and your insights.
Yeah.
Thank you.
I always know it's a good interview when I've got a page full of notes and ideas coming out of the interview. So thank you so much.
No, it was really great talking with you both. Thanks for the opportunity. Yeah.
And Jill, where can people get in touch or find out more?
Oh yeah. Well, you can go to Changemark's website. So www.changemarkoneword.ca. Or, you have my contact information. If you get contacted by folks, feel free to give out my email. I'm not the kind of quote CEO that doesn't have time to respond to people. So I always will respond to people. But yeah, no, it was great having this conversation. And I want to thank you both as well, because, it's not often that, in trials, you have the opportunity to be able to advocate for community members that you've worked with so closely, and sort of, be able to showcase that on platforms like this. Usually it's talking about, logistics of clinical trials or regulatory or GCP. And this is a really beautiful, refreshing angle. So I appreciate you for this.
Thank you very much.
No, thank you, Jill.
We'll be in touch soon, I'm sure. Well, thank you very much, Jill. Appreciate it.
Right.
Thanks so much.
Bye.
Thanks for listening to our series with Jill Fikowski. Did something from these episodes give you an idea? Do you have a topic you'd like us to discuss on the Innovating Clinical Trials podcast? If so, follow Innovating Clinical Trials on LinkedIn and message us there, or through our website at innovatingclinicaltrials.com.